Okay. Now, Dr. Rishikesh Pai, do you use any method to prevent implantation failure? Where is? He's gone. Okay. Anybody else would like to say, please?
Hi, I'm
Yeah.
Dr. Patki here.
Yeah,
I'm
Dr. Patki.
also practice
He is
on
also
infertility.
in IVF practice.
One question I wanted to ask Professor Christiansen is, would you consider doing an endometrial biopsy to choose your patients for recurrent failures instead of doing their blood test to see for any of these markers? Because I think that is the end organ which really makes the difference, one. And second is for implantation failure, I also wanted your comments on hormones which are used for immunomodulation, like some forms of progesterone, which they say increases Treg cells. So if you have any comments on these two. One is whether endometrial biopsy done at around day 21 would give you a better diagnosis to choose your patients. And second is whether you think some forms of progesterone would be also immunomodulators.
Yes, the first question, we don't have the opportunities to take these endometrial biopsies and investigate them. I know a group from Great Britain, Queenbee, have done some studies investigating NK cells in the endometrial biopsies that have treated with prednisones that have found some effects, but I still think that there's a long way before we can identify patients that can benefit from specific therapies by measuring specific cell types in endometrial biopsies. We really don't know what is the normal findings. We are really in the start of this. We will first have to define what is normal in endometrial biopsies and what is abnormal. And then the next step is to find out whether those who have abnormal values are those who will benefit mostly from therapy. So I think it's very premature so far, and we cannot give much information to this part because we don't so far have the facilities, but we might have it within the next year because we have had a maybe new coming professor in our department, Nick Macklon, and he will try to introduce some new investigations of the endometrium that we might have the opportunity in the future, but so far not. And your other question about progesterone, in none of our placebo-controlled trials have we used progesterone. The patients in our placebo-controlled trials have only got the study medicine and nothing, a placebo. But the patients that we treat outside placebo-controlled trials, we measure progesterone as soon as they have positive pregnancy test. We measure progesterone twice or 3 times within 1 or 2 weeks. And if we find that it's very low from the start, or if it's declining very rapidly, we often start vaginal progesterone in these patients. But still we don't have any clear documentation about the efficacy, but it will probably come within the next year because there's this big placebo-controlled trials, the PROMISE trial that have been conducted in Great Britain, in the Netherlands, and it's been concluded now, so I think we'll have the results from this trial the next year. This trial, they have included 800 patients with recurrent miscarriages that have been randomized to progesterone and placebo. So I think that this trial can give some of the answers about the efficacy. But so far we're using it for patients if we find a rapidly declining progesterone value or a very low value. And we had at least 2 patients where the first progesterone value we measured, the two first samples was extremely low. I have never seen in any papers that a pregnancy can survive with such low values. It was lower than 4 or 3. I cannot remember the units, but we normally say that in pregnant patients it should be more than 35, and in these patients it was only 4 or 5. And as soon as we had the first 2 measurements that were very low, we started progesterone, and both of them went to term and had healthy babies.
Okay, thank you.